second, but we are not live yet. So.
Good evening. We would like to welcome everyone to the Neuroendocrine Tumors Awareness Month webinar hosted by the American Association of Endocrine Surgeons and in partnership with the North American Neuroendocrine Tumor Society, or NANETS. I am Hunter Underwood. I am the Endocrine Surgery Fellow at the University of Michigan, and I am one of tonight's moderators.
Hi, my name's Dr. Sarah Oltmann, and I'm an endocrine surgeon at the University of Texas Southwestern Medical Center in Dallas, Texas, and I'm our other moderator for this evening's webinar. We've assembled an expert panel to answer all of your burning questions about neuroendocrine tumors. Tonight's webinar is being recorded and will be made available on the AES Facebook page, as well as the AES YouTube channel. And we'd very much like to thank NANETS for providing us with some frequently asked questions from their membership. And we'll also be taking live questions from the audience this evening. Feel free to either enter your questions into the comments section directly on the Facebook live stream. Please be aware that we will not be answering any personal medical questions or providing specific medical advice this evening. For those types of questions, please seek advice from your doctor and medical team.
So we'll first start out by introducing and getting to know our panelists. So I'm going to go around everybody's name, and if you can please tell us a little bit about yourself and your background. We'll start with Dr. Eren Berber.
Good night, everybody. I'm an endocrine surgeon at the Cleveland Clinic. I'm a vice chair of the endocrine surgery department, and I direct the neuroendocrine program here.
Great, thank you. And next, Dr. Mike Campbell.
Thanks, Hunter. My name is Mike Campbell. I'm the chief of endocrine surgery at the University of California, Davis, and I'm very excited to be part of this panel.
Next, Dr. Jaydira Del Rivero.
Hi, I am a medical oncologist at the National Cancer Institute, and my area of clinical interest and expertise, as well as research interest, is in neuroendocrine tumors, as well as adrenal tumors, and very happy and excited to be here with you all.
And last but not least, Dr. Amanda Laird.
Hi, I'm Amanda Laird. I'm the chief of endocrine surgery and of the endocrine and neuroendocrine tumor program at the Rutgers Cancer Institute of New Jersey in New Brunswick, New Jersey.
Thank you to our panelists for joining us this evening. We will now start answering our questions. As a reminder, we'll not be able to answer any of your personal medical questions or provide any specific medical advice during the webinar today.
So we'll start with a general question, and this will be first directed towards Dr. Jaydira, and then we'll direct it around to everybody else on the panel as well as we wait for some more questions to come in. So the first question is, when meeting somebody with a new diagnosis of a neuroendocrine tumor, what factors do you consider in both your laboratory and imaging workup?
Thank you so much, Dr. Hunter, for that question. I think it's very important for neuroendocrine tumors, number one, to understand whether it's localized or whether it's metastatic. A lot of our neuroendocrine tumors, when they're diagnosed, they're already diagnosed with liver metastasis, which is the most common site of metastasis. And I think it's important, number one, to identify, once we have the diagnosis of neuroendocrine tumors by pathology, number one, determine the location of the neuroendocrine tumors as well as extension of the disease. How do we do that? We do functional imaging studies, and we do what we call anatomical imaging studies. Which one are the anatomical imaging studies? Either a CT scan or an MRI, and the functional imaging studies, especially for the well-differentiated neuroendocrine tumors, the most common functional imaging studies that we use is the 68 gallium dotted scan or the 64 copper dotted scan. Either of the two, one of the questions that sometimes have is like, which one is better? I think in terms of sensitivity and detection of lesions is similarly the same, either for the copper or the gallium dotted scan. I think it's important, number one, to determine what is extension of disease, localized versus metastatic, to then guide us what will be the next treatment plan. The second thing, once I know what is the where is the neuroendocrine tumor, whether it's in the small bowel, we know that those tumors secrete serotonin, so we need to measure the hormones, either by 5-hydroxyndolacetic acid, either in the urine as well as in the blood. Again, the sensitivity is the same for the two of them. If it's in the pancreas, most of the pancreas neuroendocrine tumors, 60% of them do not produce hormone, but 40% of those pancreas neuroendocrine tumors can produce hormones. And usually we recognize those by depending on the symptoms that they have. If this is a gastric and neuroendocrine tumors, we know specific symptoms related to a gastrinoma or insulinoma and so forth. I think it's important to recognize what are the symptoms as well to guide us what laboratory evaluation we need to address, and also understand what is the as well the extension of disease. And very important as well in terms of neuroendocrine tumors grading, whether it's well differentiated versus poorly differentiated, but that's something that we can discuss more as we have this meeting ahead.
Thank you. And I'm going to pass that off to Mike for a second to talk about maybe from a surgeon's perspective in terms of those imaging studies and those functional studies. How do you think about that?
Thank you. I really agree with Dr. Del Rivero on much of what she said. I can't emphasize enough actually the importance of anatomic cross-sectional imaging in these patients as well as functional imaging. When I see these patients, one of the first things I really talk to them a lot about is their symptoms. So many of these patients are now coming to us with incidental findings and they don't have necessarily symptoms. But some patients, they have a lot about what they want to talk to you about. And the reason this helps me is it really helps me direct what type of biochemical workup I want to do. And it gives me a better idea of what I'm trying to accomplish with the surgery. One of the things that's somewhat funny about neuroendocrine tumors is, many of these are low-grade tumors, and we're often weighing the benefit of surgery versus the risk of surgery in patients, and specifically that might depend on the anatomic location of the tumor. So I talked a lot about their symptoms, what they think their symptoms might be related to their tumors, and then I look at those functional studies and I try to ask myself basically two questions. The imaging studies. The imaging studies I look at, I say, one, is this something that I could get out safely? How big is the operation going to be for me to get this out? And two, is it localized or metastatic? Metastatic basically means the tumor has spread to an area outside of where the tumor originated. And neuroendocrine tumors frequently will go to the liver. Now, that doesn't mean we're not going to operate on the patient, but it might change the type of operation I'm going to do. Perhaps I'm going to address those liver lesions during the same operation, or perhaps I'm going to do a little bit of a less aggressive primary operation because I know the tumor is already spread and I don't want to put them through a bigger operation at this time.
Thank you very much, Mike, for that answer. So it looks like we have a question from Facebook, specifically about Netspot. Did any of our panelists want to tackle this particular one?
I think I can start and maybe somebody else can comment on this, but the question is about the specific Netspot, if he's able to see everything on the scan. And if we don't see anything and the patient still has symptoms, what do we do? And I think that's an important question. And in terms of the 68 gallion DOTA scan, I mean, one important thing that we need to understand is that sometimes they're not able to detect tumors that are greater than 1 centimeter in size. I'm not a nuclear medicine physician or radiologist, but my understanding is that in order to be detected for the by the DOTA scan, it has to be a specific size. Sometimes, the neuroendocrine tumor may be in the small bowel. Sometimes it's very difficult to localize. Sometimes we can see a spot there. But one thing to know is like even very small bowel neuroendocrine tumors has still the risk to metastasize to the liver. And I think it's very important, even for the surgeons, another surgeon, that one of the most important things about surgical management of the small bowel neuroendocrine tumors is palpate the whole bowel, because there may be some small lesions that we're unable even to see in the dot of the skin. So I think it is an important question. And I think when we don't see anything on the Gallium scan and the patient still has symptoms, one thing is to measure the hormones. I always try to measure the hormones of my patients just to see where they are based on the symptoms that this patient presents, and just follow up as well with repeat imaging studies in a certain time period to know where things are. One other thing that we can do is also colonoscopy, endoscopy. We're unable to see anything on the dot of the skin. Sometimes, very rarely, is not something that we recommend to do a capsule endoscopy, because the risk of obstruction is high with this capsule endoscopy, but it's something that we could definitely recommend in those situations if we're unable to see anything on the functional imaging studies. Moreover, one last question that I wanted to mention here is that grading of neuroendocrine tumors is important, because if we have a poorly differentiated neuroendocrine tumor that doesn't express somatostatin receptors, we will not able to see it on the dot of the scan, for which another functional imaging modality, such as the FDG PET scan, may be a better scan in those situations. But of course, I would like to know the thoughts of anyone here in the panel.
No, I agree that dotatate PET is a good really resource to have, but you cannot just rely on it. You have to kind of look at the patient's characteristics, the tumor grading, location, and sometimes if it's not if it's undifferentiated, you might want to do a regular PET instead of a dotatate PET.
Thank you both for commenting on that. I'm actually going to ask Dr. Berber another question from Facebook that just came up. So post-pancreatectomy, for patients that undergo pancreatectomy for neuroendocrine tumors, what do you think the most important thing for them to keep in mind or understand post-operative would be?
Obviously, I think, irrespective of the organ, it could be pancreas, it could be small bowel. I think the most important thing for these patients to understand is they need lifelong surveillance. So they need to be monitored by an expert, and ideally in the first couple of years, definitely every 6 months, imaging that will include the chest, abdomen, pelvis. I mean, there's obviously many imaging, depends on the patient's tumor, that could be used in combination. I see that as the most important, and I'm not going to really pinpoint otherwise to anything specific after pancreas surgery. If they recover from the surgery, I think the surveillance to look for any recurrence is going to be critical.
I guess as a follow-up on that, for post-pancreatectomy, I don't know if the particular question was more getting at what to expect after surgery itself, recovering from.
I think so. It's so variable, because I mean the pancreas, there's so many procedures. You don't have to remove a big portion of the pancreas. Sometimes you just remove the tumor. We call it enucleation. Sometimes you just remove a part of it. And the most complex procedure is where you remove the head of the pancreas. It requires a lot of reconstruction, and each operation is really different. It's just I can't really pinpoint. Okay, this is really what you have to really pay attention to. Each operation is different. It's tough to really comment unless we know exactly which operation we are talking about. I mean, obviously, the most important thing for pancreas surgery is to make sure that there is no pancreatic leak, which can cause a variety of abdominal symptoms. It could be something mild where the patient is distended, maybe has to interrupt diet for a while. It could progress to significant infection requiring antibiotics, maybe drainage procedure by radiology, or even repeat operations. But I guess for recovery, that's the most critical kind of the recovery that needs to happen, is just making sure that the patient doesn't have any pancreatic leak. And unless you remove a very significant amount of pancreatic tissue, pancreatic insufficiency, where the patient's having digestion and diarrhea, is not a very frequent condition that we see in neuroendocrine patients. It's more probably seen in more other types of pancreas surgeries and for other cancer and pancreatitis. But for neuroendocrine patients, we don't really see a lot of patients with pancreatic insufficiency.
Perfect. Thank you very much. For our next question from Facebook, we're going to direct this to Dr. Amanda Laird. For patients who have non-functional tumors, what is the course for follow-up? Is it just following scans, or is there anything else that we're going to be watching for?
I assume that's pertinent to pancreas neuroendocrine tumors. And just to be clear, probably the majority of what we'll talk about in this group, I'm assuming, is gastroenteropancreatic neuroendocrine tumors. And the most common of those are small bowel and pancreas NETs. Small bowel NETs usually aren't functional unless you would consider those who have liver metastases, who have carcinoid syndrome, functional. And that's sort of a different thing. But I think the question is, if it's not making something like insulin from an insulinoma, then what's the appropriate follow-up? So I think that there are a couple different things to get, and even non-functional tumors have tumor markers that we can follow. Usually in my practice, we get chromogranin A levels. As Dr. Del Rivero mentioned earlier, you can check 5-HIAA levels as well. Some people also get neuron-specific enolase, which can be another tumor marker. And then I think that it's critical to follow long-term outcomes with some type of scan. And probably the easiest thing to get for most patients is going to be some type of cross-sectional anatomic imaging, which is a CT and MRI. But I think probably at least once a year, patients should also have some type of functional imaging, the best of which is a gallium-68 somatostatin analog scan. And then we in my practice commonly use dotatate. But I think the other thing to keep in mind is that you want to be able to compare postoperatively to whatever it was that you had preoperatively, because going back and forth and flipping between, a CT and then an MRI, or a dotatate and an octreotide scan, or vice versa, can give you a lot of confusing information. I hope that answers the question.
Can I add one point, if it is okay? Can I add one point here? I think one of the questions I always hear from my patients as well is, what is the risk of recurrence? And what do we do in those situations? And I think that it's very important to know, as Dr. Laird mentioned, pancreas and small bowels are the most common neuroendocrine tumors. And pancreas, there is up to 25% risk of relapse that can happen. And that's the reason why, and it can happen even after 5 years. So that's the reason why we need to still do a surveillance scans, even the first year after surgery. We can do scans every 4 to 6 months for the first year. And then after that, every year for at least 10 years, because the risk of relapse with pancreas neuroendocrine tumors being 20%, it can happen after 5 years. The same with the small bowel neuroendocrine tumor, it could be 20% or higher, and that's the reason why it's very important. So when I say the risk of relapse, it's also important to keep in consideration what is the pathological findings after the surgery, what is the lymph node involvement, if there is any involvement of the capsule invasion. So those are the things that we need to also keep an eye that can also guide us whether this patient going to have any recurrence and relapse after surgery. Thank you.
Thank you very much. We're going to direct another question from Facebook to Dr. Campbell. In response to Dr. Berber talking about pancreatic surgery and pancreatic leaks, can you talk a little bit about what a pancreatic leak is and how often that occurs and what patients can expect if that happens?
Yeah, it's a really great question, Hunter. And, all surgeons know about pancreatic leaks. And we know about it because often it's one of the more frustrating portions of our practice. Simple way to kind of think of it is the pancreas is a very complex organ. It secretes hormones that go into the blood and help you absorb your glucose, and we call that insulin. It secretes a bunch of other hormones, but it also secretes a bunch of digestive enzymes. We call that its exocrine function, is the term that we use in medical school. Those exocrine hormones or exocrine enzymes, they're secreted out of a large duct in the center of the pancreas that channels to the first portion of your intestine. We call that the duodenum. When we remove a tumor from the pancreas, one of the things that surgeons think a lot about is how close that tumor is to that duct and how you're going to safely be able to get that tumor away from that duct. Because if that duct has a hole in it at the end, it is very challenging to close that hole. So I want to take an example here. Sometimes, a lot of times patients will have a tumor in the end of their pancreas. We call that the tail of the pancreas. Insulinomas frequently occur there, and we'll take maybe the end of the pancreas away. Well, something called a distal pancreatectomy. And when we do that, we divide the duct in half. Now, we frequently will sew the duct closed, and we'll put 2 layers in it and put a drain next to it and everything else we could do. But 40% of the time, that pancreas will start to leak again, those digestive enzymes out. And the problem with those digestive enzymes is their job is to degrade protein. And your body is made of protein. And therefore, what happens is you start to get a very adverse reaction to those enzymes, and it's frequently associated with infection because of the dead tissue provides almost an auger plate for those infections to set up. So anything that's leaking from the pancreas, we call a pancreatic leak. How common are they? Actually, they're very common. In pancreas surgery, we divide these kind of into 3 different types. Those that we could kind of control with the drain, those that sometimes we don't have to do much with, and then those we actually have to go back to surgery on. And depending on how bad the leak is, it depends on how long it will last and how much of an intervention we have to make afterwards.
Thanks, Mike. Our next question from Facebook is, we're going to direct this to Dr. Amanda Laird. If you're having symptoms such as chronic diarrhea, bloating, gas, upper GI pain, are those due to the surgery, or could this be from something else, or is this related to the PNET?
I'm guessing since there's the qualifier is due to having the surgery, you're asking about having those symptoms after either a pancreas or small bowel resection. If you have those symptoms before surgery, it could be different. So often those would happen before surgery, maybe from a small bowel neuroendocrine tumor that's causing foreshortening in the mesentery and a bowel obstruction, or an intermittent bowel obstruction. After surgery, and probably most common after pancreas surgery, it sounds like those could be as a result of pancreas exocrine insufficiency. So just like Dr. Campbell mentioned before, with the pancreatic digestive enzymes, sometimes if you've had enough of the pancreas removed, you may have to take a supplement that can help with those symptoms. So those sound a lot like pancreas exocrine insufficiency to me. Having said that, sometimes resections for these kinds of tumors, whether they're small bowel or pancreas, can be quite complex. And so if you've had surgery, it's probably a good idea to see your doctor and consider having a thorough physical exam with or without additional testing to determine the exact cause.
And I guess a short order follow-up on that too, and whether it's to Dr. Laird or Dr. Campbell, pancreatic leak, what time frame should patients expect that to happen? Right after surgery, remote from surgery?
I'm happy to take that. Most pancreatic leaks occur fairly close to surgery. We usually see these present within the first week. Occasionally, we'll see delayed presentations where a patient goes home and then gets sick and comes back into the hospital, and we get a CT scan and we realize they have a leak. But usually temporarily, definitely within the first 6 weeks for sure. Delayed leak, I can't say that I have ever seen that. I never say never in medicine. I learned that through years of practice now. But it'd be extremely uncommon for you to develop a leak, years after surgery.
All right, next we're going to direct another question to Dr. Eren Berber. So can you talk a little bit about the difference between grade and differentiation in tumors, and if all grade 3 tumors are considered to be aggressive?
Sure. So differentiation is part of the information we get from the pathologist when they look under the microscope to the cells related to these neuroendocrine tumors. Generally, for any type of cancer, when we say well differentiated, meaning that the cells demonstrate some typical features of the cancer that we are looking at, and there's not much variation in the cells when you look under the microscope. Poorly differentiated is when mean that the cells are looking much less like the characteristics of more kind of common garden variety tumors that we see, and generally poor differentiation for any type of cancer suggests kind of the maybe a more aggressive tumor with a worse prognosis. And regarding the grade, the pathologists, again, under the microscope, they look at and grade the activity, if you will, of the cells dividing under the microscope, and by analyzing it, they assign a number on how fast maybe the cells are dividing, and there are a couple of indexes that they look at, something called mitotic index, again, like regarding how fast the cells are dividing, or we call Ki-67 index is a kind of more sophisticated number that we use, and it's and they generate a number, and then generally, and grade 1, 2, 3 are the grades that they assign, and 1, 2 are meaning that the cells are not dividing too fast, and 3 is dividing faster, and they also give us some numbers, and the way we use them is they give us a little bit sense of how indolent the cancer is predicted to be, and that really affects your decisions about when you're thinking about surgery versus maybe systemic therapy first to the patients, or regarding how aggressive an operation you want to plan. But basically, differentiation and grades mean a lot to us as neuroendocrine experts.
Can I just add a very small comment there, because I think
Please,
it's important about a grade and differentiation, even though is related but not necessarily the same, as you very nicely described, Dr. Berber. But I think that one thing to keep in mind is that all poorly differentiated neuroendocrine cancers are grade 3. However, not all grade 3 are poorly differentiated. And the reason why I'm saying that is because we have the well-differentiated grade 3. And it's important to know and understand, and that's why it's always, whenever we have a patient with neuroendocrine tumors, having a good pathologist who can read that specimen is very important, because treatments also depends on the grade and differentiation, as we discussed earlier. Thank you.
As a very quick follow-up on that, Dr. Del Rivero, on Facebook, someone just asked, can the grade change over time, or is that set?
Yeah, that's a very, it's a very important question. And the reason why is because well-differentiated neuroendocrine tumors, as Dr. Berber will describe, based on the Ki-67, we have grade 1, grade 2, grade 3, based on the number, grade 1 less than 3%, grade 2, 3 to 20%, and grade 3 greater than 20%, but usually less than 50, 55%. So that's kind of what we see the differentiation. And those tumors are, especially grade 1 and grade 2, they're very indolent, they're very slow growing. However, but sometimes I see, and over time, that the biology tends to change a little bit. And in those situations, when I see that, I like to do a biopsy as going to understand at that point what is a Ki67, because it can differentiate, doesn't happen very often, but it can differentiate. And that's important. We see a change in the biology in the neuroendocrine tumor. It's important to biopsy to understand if the number of the Ki67 change, because again, that can definitely guide me about treatment options.
Yes, for the lay people, can you go into a little bit more detail about what exactly is Ki67?
Yes, great. As Dr. Berber mentioned earlier, is how we're able to look under the microscope and how the cells are able to divide. So the Ki67 is an index of differentiation of the cells and how the cells are able to divide. So low grade, less than 3%, those cells are very, very slow, dividing, very slow growing tumors compared to a Ki67 of 50, 60, or 70%. I hope that answered the question.
It's
Next-
basically index of how fast the cells are dividing and hence how aggressive we predict them to be.
Thank you. So this next question is going to be for Dr. Amanda Laird. So if someone is diagnosed with a neuroendocrine tumor, does that mean that their family members are at risk of that? Is there any genetic testing that's indicated for family members of these patients?
So it depends on the specific clinical situation, and it depends on the patient's existing family history, I would say. Largely, they're not inherited, but you can see neuroendocrine tumors, specifically of the pancreas, within something called multiple endocrine neoplasia type 1. This just should be suspected if you have a pancreas neuroendocrine tumor and also have a history of a high calcium. We also see other tumors in endocrine glands in MEN type 1. The third most common type is pituitary tumors, but also you can get benign adrenal adenomas. You can get tumors in the thymus, for example. So it's uncommon, but I would say that that's part of a visit with your specialist to that he or she would take a good family history and a good personal history to determine whether or not you're at risk for one of these things.
I hope, yes, can I add some, and the reason why is because here at the NIH, we see a lot of those familial syndromes. I think something, and I do get that question a lot from my patients, like if my neuroendocrine tumors is familial, less than 10% of pancreas neuroendocrine tumors are familial. Dr. Laird mentioned about MEN1. The other one is BHL. NF1 is the other one, on neurofibromatosis type 1. That's the other one that has been associated with pancreas neuroendocrine tumors. These conditions are usually associated with pancreas neuroendocrine tumors, not necessarily with the small bowel neuroendocrine tumors. There is a familial carcinoid syndrome, and it actually was described originally by Dr. Wand here at the NIH. He's an NIDDK. However, it's exceedingly rare. It's only a few families. It's usually multiple carcinoids in the bowel, and also multiple family members are affected. So it's exceedingly rare, but Dr. Wand from here in NIH has described the familial carcinoid. But most of the familial neuroendocrine tumors are associated with pancreas neuroendocrine tumors. And also in those situations, we call cancer predisposition syndromes. There are other clinical manifestations associated with that may not be necessarily a pancreas neuroendocrine tumors. Like, for example, the BHL, we have the CNS hemangioblastoma, the kidney cancer, and so forth. And Dr. Laird described very nicely about the MEN1 clinical manifestations. But yes, there are other clinical symptoms associated with these cancer predisposition syndromes. And depending on what is the cancer that is present in the patient, there's different guidelines in terms of follow-up and screening as well.
Thank you both for that. Staying on the trend of some of the genetic and familial issues, let's transition a little bit to pheochromocytoma and paraganglioma. Dr. Campbell, If someone presents to you with a new diagnosis of pheoperganglioma, what are some of the initial guidance you give them, and what's usually your primary clinical concern?
Yeah, it's a great question, Sarah. You know, one of the things we teach the residents is to have, you know, a very low index of suspicion with pheochromocytoma for a familial syndrome. Approximately 30% of patients with pheochromocytoma will have a germline mutation. So in other words, a mutation that's running through the family that leads them to have a somewhat uncommon diagnosis. And we send all of those patients over for genetic counseling that we see. Clinically, there's a couple of things that come through my mind when I start to suspect this patient may have a familial syndrome associated with it. And I think some of that's already been mentioned. And that is that none of these really familial syndromes run in isolation. Patients with multiple endocrine neoplasia type 2 don't only get pheochromocytoma. They get medullary thyroid cancer, they get parathyroid tumors, and they can be subject to other tumors too. And as an endocrine surgeon, we try to think about these all and how we're going to best manage the patient over the long term. I think another thing that's really important with the familial syndromes is they're much more likely to have tumors in both adrenal glands. When you have tumors in both adrenal glands, you have to be able to plan your operation accordingly, not only to take out the tumor, but to think long-term about whether you're going to be able to save some of that adrenal gland for the patient and keep them off of long-term corticosteroids. And what is going to be your goal down the line if the patient does recur in that remnant adrenal gland? And then finally, there are some pheochromocytoma syndromes, such as the succinyl dehydrogenase syndromes, that will present with fairly aggressive paragangliomas throughout the body. And you have to be familiar with the imaging protocols of those other locations of those paragangliomas that you might don't want to miss when they're specific to that syndrome.
Great, thank you very much, Mike. To follow up on that, Dr. Berber, do you mind going into a little bit more detail about how you get your patients prepared for surgery, whether it's adrenalectomy or removal of a paraganglioma? What are some considerations for the patient? And can you talk a little bit about the surgery as well?
Yeah, preoperative preparation of the patients with pheochromocytoma paraganglioma is very important. Actually, is as important as the surgery itself. As mentioned before, these patients have overproduction of certain blood pressure hormones, which require the patients to be placed on special medications. We call them alpha blockers. These medications blocks certain these hormones. And the kind of the objective is to make sure that at the time of surgery, the patient will remain stable with all the manipulations around the adrenal glands or the paragangliomas. Otherwise, they have this really a threat of significant hypertensive crisis if they are not prepared appropriately to surgery. So they're placed on certain medications. We call them alpha blockers. There are a couple of them available, and with their endocrinologist, the best option could be made for the patient. And I'm not going to go into the specific drugs. And then while waiting for the surgery, the patients have to make sure that they keep their blood volume expanded by increasing their fluid intake and also salt intake, because one of the issues at the time of surgery is after remove those glands, then they would be at risk for developing significant low blood pressure. So they need to really keep their blood volume expanded before the surgery. This really requires a teamwork before the surgery, with the patient, the surgeon, and the endocrinologist really being part of this team and really communicating to make sure that patient is optimally prepared to surgery. And other than this preparation to surgery with these alpha blockers, if their patient's heart rate goes about 100 while being on this medication, they also need to be placed on another medication. We call them beta blockers. And then this should be the order. You should not really start the patient on beta blockers first and then alpha blockers. And the other thing is just preoperative, making sure that the patient is really assessed in a multidisciplinary fashion just by getting the genetics team on board as well. Making sure that the surgeon understands whether he or she is dealing with a patient with we call a sporadic, meaning that without any familial disease type of process, or whether the pheochromocytoma or the pancreas is part of certain syndromes related to some genetic alterations, which really require a different approach. Sometimes you might have to think about removing both glands, maybe look for some additional pathologies that might be also present in the patient.
Thanks, Dr. Berber. I'm going to stay on the adrenal topic and ask Dr. Amanda Laird about if somebody has a resection of a pheochromocytoma, what do you think the risk of recurrence of that would be for either a pheo or a paraganglioma?
The recurrence rate in general is somewhere around 10 to 15%. It's much higher than that in a genetic syndrome. And I can't quote you the exact number, but the management is different. And Mike mentioned this a little bit earlier, but when you have a known genetic mutation, I think it's critical to try to preserve as much adrenal tissue as possible at each operation because of the lifetime risk of need for subsequent operations. That has to be balanced, of course, with the individual patient situation and age, and with the tumor-specific characteristics, such as location within the adrenal gland and size. There are some tumors that happen in a location in the adrenal gland that it would just be impossible to do anything but a complete adrenalectomy. However, if at all possible, we like to take out just part of the adrenal gland. And that's something that you can do with these type of tumors because they present as a focal tumor, and that's in contrast to tumors of the adrenal cortex, which can occur as a result, the disorders can occur as a result of either a single cortical tumor or cortical hyperplasia. So it's important to do a full adrenalectomy in those situations. It's unusual to have hyperplasia of the adrenal medulla, which is the layer that, or the part of the adrenal gland that pheochromocytomas occur in. When tumors are larger, it's almost impossible to preserve any normal adrenal gland. And we know that there's a size correlation between the size of the tumor and risk of malignancy. So as tumors get larger, the risk of malignancy begins to exponentially increase. And so it's a better oncologic operation to take out the entire adrenal gland at the first operation. And again, it's almost impossible to save normal adrenal tissue in that situation. Anecdotally, I will tell you that I have done taken out as much as, let's see, 1 2/3 of the adrenal tissue in a single patient. And it was enough to avoid adrenal insufficiency so that the patient didn't need supplemental steroids unless she got sick. So if she got the flu or if she had surgery, she had to take additional steroids, which we call stress dose steroids. But aside from that, she was okay. So I think that any effort that that we can give in those situations, it's key to try to preserve adrenal tissue for as long as possible.
Thanks. And we're going to switch gears a little bit and direct this next question towards Dr. Del Rivero. So we've talked a lot about patients who have surgical neuroendocrine tumors that are resectable, but what options exist for patients that have metastatic disease if they don't have disease that the surgeons feel are resectable?
Yeah, great. Thank you so much for that question. It's important to understand, in my opinion, it's important to understand, number one, biology of the neuroendocrine tumors. We need to understand how the tumors are growing, whether they're fast, whether they're slow growing. I think that's what I mean by understanding the biology and in terms of these neuroendocrine tumors. We also need to understand what is extension of disease, whether it is only in the liver, or we also see disease outside the liver. We also need to understand whether the tumor is expressing the somatostatin receptor that we see on the dotted skin. And that will definitely guide us as well to understand about what are the treatment options. I do believe that the neuroendocrine tumors needs to be discussed in a multidisciplinary team with nuclear medicine, surgery, oncology, and so forth to understand all those factors that I just explained, so that way we can then guide what will be the best treatment options. So the way when I see a patient with metastatic disease, whether it's in the pancreas that is well differentiated, slow growing tumors, one thing to look is like how fast is it growing. If it's very slow growing, not changes within the skin, it's okay to observe first. And then after that, if we feel like there is some growth, the first line treatment for these neuroendocrine tumors is usually what we call somatostatin agonists, either lanreotide or octreotide or sandostatin. Those are the somatostatin agonists. If the patients are on these treatments and then I see evidence of disease progression, then we need to understand whether they are positive in the dotted skin, because PRRT with Lutathera is a treatment option. And if it is negative on the dotted skin, discussing about pancreas neuroendocrine tumors, then we have other treatment options like sunitinib, everolimus. So those are the other treatment options that we have. Now, if we have a large volume disease and is rapidly growing, I think cytotoxic treatment, what I mean with chemotherapy, may be an option for them. Then capecitabine, temozolomide is one of those treatments, and we have other treatment options as well in terms of the chemotherapy options for those patients. Now, in terms of the small bowel neuroendocrine tumors, so again, somatostatin agonist as a first line, is there is evidence of disease progression. First thing, if it's positive on dotted skin, PRRT with Lutathera is an option. If it's not positive on dotted skin, then we have everolimus as an option for neuroendocrine tumors. Now, recently at the NANETS meeting, it was also discussed about different tyrosine kinase. So what does that mean? Those are medications that block the blood vessels. Lenvatinib is one of the medications that was discussed there, and they saw some evidence of efficacy on pancreas and as well as extra pancreatic neuroendocrine tumors. The same with surufatinib. So surufatinib is the data seems quite promising. I know that Dr. Desari from MD Anderson is trying to submit it to the FDA for approval. So it's something that we need to look into that. Cabozantinib, there is a study with Dr. Jennifer Chen at Dana-Farber. I think there are different treatment options. The issue, though, as a neuroendocrine tumor physician or expert that we see this patient is sometimes to understand what is the sequence, because sometimes we don't know what is the sequence in order to give these different treatments for neuroendocrine tumors, and when we need to give it, whether PRRT we need to give it earlier or later. So those are the things that I think we need to understand more about these neuroendocrine tumors to guide us about sequencing of these different treatments. So I don't know if that answered the question, but that's kind of like how I think in terms of the management of advanced neuroendocrine tumors. Oh, and one thing I wanted to mention as well, liver-directed therapy. So I think if it's only liver-dominant disease, I think liver-directed therapies can also be an option to discuss. Surgery in some situations, even in the metastatic setting, can also be discussed. I mean, I know Dr. Berber and Dr. Campbell, Dr. Laird, please, feel free to comment that situation. But even in the metastatic setting, there are certain subset of patients that may benefit for surgical resection of their primary tumor or liver metastasis in those situations. So something to keep in mind.
I think that was really a good explanation of the medical options we have for these patients. And I would like to also emphasize that, one good thing about this neuroendocrine tumor is that for most of the patients with indolent disease, those, excluding those which are really high-grade tumors, what we call surgical debulking, meaning that surgically going and removing as much cancer as we can, even up to 70% of the total cancer volume, really benefits the patient. So there's a really role for extensive debulking, meaning removing as much as you can. You can remove the small bowel tumor, burn or cut out the liver tumors. you know, maybe use some radiation treatments afterwards for isolated disease. These are very helpful in the care of these patients. But I'm going to emphasize like multidisciplinary care, so you really have to have all the experts and may possibly discuss the patient at tumor boards to really decide what the best option for a given patient would be.
I guess our next question will kind of build on that for Dr. Laird. So when patients have a functional versus non-functional tumor, does the objective of the operation change, or does the approach of operation change based on that hormonal activity?
So I think this is a good question, and I think that this might generate a little bit of discussion and or controversy from the group. So I like this question. I can tell you what my own personal approach is and what my thoughts are on the subject. And I think that probably the most controversial thing I'll say is about non-functional PNETs. And that I think that non-functional PNETs should be resected via an anatomic resection. And by that, I mean that it's either a pancreatic duodenectomy, which is resection of the head of the pancreas, or a body resection, which is uncommon, or a distal pancreatectomy, which is removal of the tail or the end of the pancreas. And the reason is because, or the reason that I believe this is because we're operating on those tumors because we suspect that there may be some risk of malignancy, and the operation is done to limit the potential harmful effects of metastatic disease. Some people treat those with an enucleation, which is just local removal of the tumor. But in my opinion, I think that by doing that, we're sort of violating the basic principle of why we're doing the operation to begin with. I think that it's fine to remove functional tumors through enucleation. The majority of insulinomas, which are the most common, are benign, and an enucleation is a good operation for treatment of those, provided that you can do it without injury to the pancreatic duct, which is the thing that you would worry about most in that situation. You know, there's no randomized data on this topic. I think mostly what we have are outcomes from individual series. And so I'd love to hear everybody else's thoughts. I think that what I've said might generate a discussion. So I'm happy to hear what everybody else has to say.
You know, if I could make a comment on it, definitely you know, whether the patient is functional or non-functional really affects our clinical decision, because there are a couple of good things about these cancers. You know, one of them is that they're slow growing, but the bad thing is they would be more extensive, or they would you know, come back. But the good thing is, you know, you would have a lot of options to treat those tumors. So if the patient has a functional or non-functional tumor, really affects our decision to intervene and perform surgery or other liver-directed or pancreas-directed therapies when the patient's presentation and the amount of cancer we're dealing is in the gray zone. I mean, let's say the patient has multiple spots in the liver. We call them liver metastasis, has the primary tumor, which is not. And then you have to really think about, is the patient having symptoms or not? If the patient is having symptoms, then we are more aggressive with our treatments. For instance, for the liver, you know, you can do surgery, or you can do some intervention radiology. We call them liver-directed therapies. But if they're not hormonally active and they don't have symptoms of, for instance, carcinoid syndrome, then you may want to monitor the patient instead of being aggressive with the treatment. So it really affects your decision in the patients with a little bit less obvious, you know, options for treatment.
You know, I think Amanda and Eren have kind of hit on some key points, and I just want to reiterate more than expand upon any of them. But these tumors are incredibly complex from a surgical standpoint, because it is the ultimate balance of risk and benefit in these patients. We are constantly, as surgeons, debating whether the surgeries we're doing are helping the patients and whether they are something we want to do or if it's better not to do it. And these tumors are really the epitome of that, because some of them are so indolent, we're not sure if we did nothing, they would do much. And some of them, when we first find them, they're everywhere and we're wondering, how do they possibly get that far? And so, I think this really highlights the importance of going to a center that has some experience in this, because it's not as straightforward as perhaps some other tumors are, where we have a standard operation and we do that standard operation every time. This is a really much more patient, individualized approach, and I think a very multidisciplinary approach. And I think Eren hit the nail on the head, which is, if this patient is having symptoms, we're more likely to do something, but maybe I'm not the best person to do something. Maybe what this person really needs is some really good radiation, or maybe they need somebody that is really good with radiofrequency ablation of the liver to take care of those symptoms for them. So, and kind of coming full circle, I think we could debate a lot about the right operation for individual patients, but I think making blanket statements in these patients are very, very, very difficult.
Thank you. And our last question, and we're kind of changing the subject one last time, but this goes back to Dr. Del Rivero. You had mentioned previously about, depending on the dotatate scan, potentially doing PRRT. And can you just explain a little bit more about what PRRT is and how that works and what sorts of patients would benefit from it?
Sorry, thank you so much for that question. And PRT stands for peptide receptor radionuclide therapy. And it's just the modalities, like when I say earlier, TKIs is just a type of treatment. And that's why I say PRT with Lutathera, because Lutathera is what we use in this situation for neuroendocrine tumors, and is FDA approved for pancreas as well as for small bowel neuroendocrine tumors. And when do we know a patient is eligible for Lutathera? First, we need to have a positive dotatate scan. So we discussed earlier about the dotatate scan. So neuroendocrine tumors, especially the well-differentiated neuroendocrine tumors, express the receptors on the surface of the cells. And when you give the injection of either by the skin or by the treatment, it goes and binds to those receptors of the neuroendocrine tumors. That's why dotatate scan has become kind of like our first imaging modality for these neuroendocrine tumors. Now, once we know that it's positive on dotatate scan, and again, now we have two types of dotatate scan, either copper or 68 gallium dotatate scan, then we say that this patient is eligible for PRRT with Lutathera. And in that situation, what it is a type of IV radiation. It's a type of radiation that goes and binds to the surface of the cells to kill the cancer cells. That's one form of treatments. I think now the field is evolving, and I think the management of neuroendocrine tumors as well is evolving, because now we have the alpha emitters as well for the treatment of neuroendocrine tumors. Dr. Delpasant has a treatment, a clinical trial for that as well, and we're excited to also learn what is the results of these alpha emitters as well. And the same with positive dotatate scan. This is more specific to the tumor cells with less collateral damage, less toxicity. That's what's expected. And I think it's important to know what the results of these alpha emitters as well. We have one technetium, dotatate treatment, and yeah, I think that's one thing that I want to mention earlier, because I think something that I didn't touch was about the poorly differentiated neuroendocrine carcinomas. I think the management of metastatic disease on the well-differentiated, I think we describe what are the options, but for the poorly differentiated neuroendocrine carcinomas, we know in the situation is chemotherapy. And usually the chemotherapy for those patients is cisplatin and etoposide. Now we have other treatment options as well. But it's important, as I discussed earlier, to know what is the differentiation of these neuroendocrine tumors, grading, what is the extension of disease, whether they express somatostatin receptors, in order to guide us what is the best treatment option for those patients.
Thank you very much. As we approach the top of the hour, we would like to thank our viewers and supporters for joining us this evening. Thank you to everybody that asked questions on Facebook, and a special thank you to our expert panelists for taking time out of their busy schedules to answer all the questions and discuss neuroendocrine tumors. We also want to thank NANETS for their support.
As a reminder, this session was recorded and will be available at the AES Facebook page on the AAES YouTube channel within the next couple of days. We apologize that we weren't able to get to all of the questions that came up on Facebook Live. For more helpful information, patients, please be sure to visit the AAES patient education website, and you can find that at www.collectedmed.com/AAES patient education. And that link will also be present with the Facebook live stream. Thank you again to everybody else, and have a great evening.
Thank you so
Thank
much.
you very much. Bye-bye.
Thank you. Bye.